Now, another case for you. What do you think about this nodular lesion? Because this is nodular lesion. Clinical differential. Many things. What do? Wow, very good, very good. Let's go into dermoscopy. Kaposi. Okay. Yes. Why? Because in Kaposi it was described this rainbow pattern with these images due to the constitution with vessels and fibrosis of the tumor. And this was nicely described in a publication some time ago, but these are phases of Kaposi sarcoma. And this is the correlation with histopathology. And many times this is easy because the patient has many lesions like this. But I'm sorry, this is not specific because the rainbow pattern is also seen in other lesions. Look, all these lesions exhibiting rainbow pattern. And this is an aneurysmatic dermatofibroma. This is a pilomatricoma, dermatofibroma again, and melanoma even. So rainbow pattern, it's another clue, but it's not specific. And this was described by our co-workers in Spain in these lesions. Well, another nodular lesion. I'm speaking about difficult nodular lesions. Tumor in the upper arm of 67 years old patient with this image. What do you think? What can be? Could be melanoma, it could be, okay. Oh, very good. You're very good clinicians. Well, here you have some key points for the diagnosis, here in the dermoscopy. What is here? What do you have in here? Well, pilomatricoma is exhibiting these white structures due to the calcification. And by dermoscopy, they are nicely seen. Of course, in addition to this, you have this pattern that is not very specific at all, and ulceration is very frequent. This is the description of pilomatricomas that we could do. And this is what I recommend to visit in this paper with these whitish structures that are really particular in our view. In pilomatricoma. This is the description. Of course, they can exhibit ulceration, structuralist, gray-blue areas, the same than in melanoma and many other tumors, but remember these irregular white structures. In the clinic, you have also another sort of nodular lesions. I'm not going into detail in this because this is leishmania. You have to suspect because all the information is important, but by dermoscopy, we could describe that leishmania is exhibiting these yellow tears, these images that are really very nice when they are present. And if you see this is leishmania. Dr. Puig will tell you more about in 5 minutes. And finally, to finish with this talk, I want to share the final case with you, because this is a real case, and I think it's very important. 71-year-old woman with a previous superficial spreading melanoma in 1990, and familial melanoma and mutation. Again, we have many families and patients with mutations, and also atypical nevus syndrome. With this lesion on the face, and with this dermoscopy, immediately, you know very well that this has to be nodular melanoma. Atypical vessels, some remnants of pigmentation, etc. Okay. The patient was not aware of this lesion. This is an old lady, but it's a pretty nice lady, and he's looking very nice, but he considered that this was just a nevus. And this confocal microscopy. You will see something about confocal microscopy, but I want to share with you the confocal microscopy in this case. This is the epidermis, normal epidermis in this case. What is strange in melanoma? In melanoma, normally epidermis, the honeycomb pattern, it's lost. In this lesion was not. we could see these images, strange images in the dermoepidermal junction, thickening of the dermis, and these were the nest of cells that we could distinguish by confocal microscopy. These are nest of cells with atypical cells with distinct size and refractivity, and this is in favor of melanoma with fibrillar structures around. Here you can see the cells inside these images with vessels in confocal and vessels in confocal. Well, this was indeed a very thin, 1 millimeter indeed, nevoid melanoma, nodular one. And we could do the correlation. But what I want to share with you is that this lady, of course, had this lesion removed, but looking here, in 6 weeks, we had this other nodular lesion. And this was this lesion that was, of course, for us, absolutely banal at this time. But this lesion was growing 6 weeks, and in the control visit after the excision of the tumor, and waiting for the white excision, we could see this. What is this? Okay, this lesion. Go into dermoscopy. Not much. Not much. And if you tell me, what do you think? Maybe this could be coma vessels, I don't know. But it's a strange thing. Of course, it's a growing lesion, a fast-growing lesion. It has to be something else, and we have to remove this tumor. Yeah? But this is to say to you, be aware of nodular lesions, because sometimes they are very subtle when they are small lesions. And we did confocal, and confocal again, very similar. Honeycomb pattern, epidermis was preserved, very normal. And look at here, the same finding. So it was exactly the same than the primary. And this was satellitosis. Melanoma, as you can see here, but a small one. Satellitosis and nodular melanoma can be very similar, and they exhibit a lot of patterns and dermoscopic patterns that have been described. And maybe next time I can share with you this consideration. But what's important is that with confocal dermoscopy and histopathologic correlation, we strongly believe that nodular melanoma is something different than superficial spreading melanoma. Also, molecular analysis is telling more about this. And this is important for diagnosis, prognosis, and treatment of patients in the future, of course. And why is different? Because in nodular melanoma, different from superficial spreading melanoma and nodules in superficial spreading melanoma, is different. Epidermis is preserved, it's not affected, and all the findings are in the dermal component with milled pagetoid cells. And this is finding important because we think that they are very similar to satellitosis many times. And this is in favor of a dermal origin of nodular melanoma. We have to consider many other issues, and in the future we will tell you more about this. But this is just to tell you that we organized this training course in confocal if somebody is interested in Barcelona in January. And my conclusion says, be aware nodular melanoma is a fast-growing lesion, and that can be a very diagnosis challenge, can be a simulator of everything. And we can detect these very difficult lesions by dermoscopy, and also using, of course, our brain. And this is to say, thank you so much. This is my team, and see you in Barcelona. Thank you.
Thank you very much, Giuseppe. Quindi abbiamo visto un bel po' di robetta seria. In genere qua...
Il microfono è spento.
Spento?
Ah, sì.
Ok. Sì, eccoci. Dicevo, abbiamo visto un bel po' di robetta seria, no? Un po'... anche un po' spaventosa, in genere quando, e il punto è questo, avviene a un certo punto in questi corsi il momento che le informazioni sono tante e uno comincia a dire Oddio, Madonna, questi sono troppo difficili questi casi, però secondo me dobbiamo fare un bel respiro, ingoiare il rospo e incamerare tutta questa morfologia nella testa, perché ci servirà poi quando torniamo al lavoro. E la vita reale è molto più facile di questi. Questi sono casi veramente eccezionali, che però è importante conoscere. Poi ne parliamo anche con Susanna, e anche io ne parlerò, perché con le lesioni blu facciamo un po' un punto di tutta questa situazione. Giuseppe, grazie molte. Grazie.